So may I start?
Uh, Hello, everyone. Today we'll have our meeting, and we have a couple of items in our agenda. Dr. Salam and his team will be working and presenting the topics. And now I'm going to hand it over to Dr. Salam. Please go ahead.
Good evening, everyone. I hope all you're doing good. Thank you, Dr. Nader, for introducing our team. And thank you all for joining our meeting for today. So we'll start our first part of the presentation with Dr. Sameera. Are you ready?
Yes, I'm ready. Okay.
Okay, so you can start.
Okay. Hello, everyone. Can you see my screen? Hello, everyone. Can you see my screen?
Yes.
Yes. Okay. Okay. Sorry. Sorry. Um, Hello, everyone. Good evening. Hope you are okay. My name is Dr. Sameera Mohamed. I am from Page 1 team. Today, we're gonna discuss the sleep issue. Our objective for this session is to describe age-related changes in sleep, the common psychiatric and medical and neurological causes of a sleep problem in older adult, an office-based objective method of evaluating sleep, an appropriate treatment of a sleep problem in older adult. Okay, so we start the topic we're gonna cover is epidemiology and change in sleep with aging, evaluating of sleep, the common sleep problem, change in sleep with dementia, sleep disturbance in the hospital, and sleep in long-term care setting, and the management of insomnia. So regarding the epidemiology, sleep problems are common in older adults, particularly those with comorbid medical condition and psychiatric illnesses. The risk factor for sleep disturbances are chronic illnesses, the multiple medical problem, mood disturbance, and less physical activity and physical disability. Primary sleep disorders that increase with age are common. There are three: sleep-related breathing problems, obstructive sleep apnea, the restless leg syndrome, the circadian rhythm sleep disorder. Insomnia is more common in women than in men at all ages, and it have to be and the self-reported sleeping difficulties are more common in older African Americans, particularly women and those with depression and chronic illness. He said that psychiatric illnesses and physical disease are risk factor for sleep disorder. Studies that suggest approximately 5% of older adults use prescription sedative hypnotic on a daily basis. Insomnia has been reported as a predictor of death and nursing home placement in older adults, particularly in older men. Subjective sleep disturbances is associated with a worse health-related quality of life in older adults. And there is an association between worse sleep, measured subjectively and objectively, and the subsequent cognitive decline in older adults. Now we are going to talk about the sleep changes in with aging. In general, the sleep cycle have two parts: the non-REM and the REM. And the non-REM itself has three parts: stage one and stage two and stage three, called N1, N2, and 3. So now we see the total sleep time is decreased with older age, and the sleep latency, which is the time to fall asleep, the time you take from wanting to sleep to actually falling asleep, is increased or no change with older age. Sleep efficacy is the time asleep over the time in bed. So the time you spend in bed in total and the time you spend it sleeping is decreased with older age. The daytime napping increases with age. Stage 1 and stage 2 increases, but the slow wave stage 3 decreases. And we have the percent of rapid eye movement decrease. And wake after sleep onset, so you wake multiple times or you wake after you've fallen asleep, is also increased with older age. So how can we evaluate the sleep? We have common screening question. Is the person satisfied with his or her sleep? How the sleeping patterns? Does the sleep or fatigue interfere with the daytime activity? Do you wake up fatigued or you cannot concentrate during the day? Does the bed partner or other complain of unusual behavior during the sleep, such as snoring, interrupted breathing, and leg movement? All can lead to clue for other diagnosis. Patient sleep log can be helpful, supplemental with information from the bed partners and other of or violate the sleep questionnaire. We do a focused physical examination for the patient guided by the evidence from the history. So we take proper history and then we do a physical exam and conduct a mental state testing, a mini mental test. We focus on memory and mood problem, particularly depression. So we see if he has like a comorbid psychiatric problem. And we do finally the lab testing guided by the finding in both history and physical exam. Okay, the testing mainly done in sleep studies is polysomnography is indicated if the primary sleep disorder is suspected. So it is a gold standard for sleep study. Main diseases are sleep apnea, narcolepsy, and periodic limb movement disorder, and violent or other unusual sleep behavior during sleep, such as like sleep terror and other diseases, narcolepsy, other sleep symptoms that do not respond to treatment. So in home, portable monitoring screen for sleep apnea. So it detects like a cessation of breathing during the sleep. A rest activity monitor estimates sleep versus wakefulness and may be used in nursing home setting to identify the circadian rhythm sleep disorder. Now we talk about the common sleep problem. First, we talk about insomnia. Insomnia disorder is defined by the DSM-5 as difficulty initiating or maintaining sleep and waking up too early, associated with a daytime impairment such as fatigue, poor concentration, daytime sleepiness, and concern about sleep. So insomnia that you have difficulty trying to initiate or maintain sleep at night. Symptoms must occur at least 3 times per week, and for chronic insomnia, symptoms must have been present for at least 3 months. Depression and anxiety are common psychiatric problems that are associated with insomnia. Treatment of depression may improve sleep abnormality. In general, every psychiatric disorder, we need to treat the medical condition or the comorbid condition to better treat or better control the psychiatric problem. The lack of attention to sleep compliant in older depressed adult can make depression less likely to be responsive to treatment. Caregiving can be associated with the sleep difficulties. A sleep disorder in older adults are associated with increased suicide risk. So it is a major problem. We have to treat it. Now talking about the example of medical problem associated with insomnia. Common diseases can lead to insomnia like arthritis, hypertension, heart disease, lung disease, stroke, neurodegenerative disorder, GERD, nighttime urination, pain, paresthesia, cough, and nocturnal dyspnea. All the symptoms that can lead to making the patient wake up multiple times or cannot fall asleep due to pain. Medication and agent that can contribute to insomnia, particularly if taken near bedtime. Agent that increase urination, diuretics, stimulant agents like caffeine, sympathogenic bronchodilator, activating psychiatric medication. Agent that can cause nightmares and impair sleep. So there are antidepressant, anti-Parkinson agent, antihypertensive medication, and cholinesterase inhibitor. Chronic use of sedative may cause light, fragmented sleep. While chronic use of sleep medication may lead to tolerance, so they no longer work if you take them, and rebound insomnia can occur when chronic use of hypnotic is suddenly stopped. Alcohol abuse is often lead to lighter sleep of shorter duration. The sedative and alcohol can worsen sleep apnea and should be avoided in those with untreated sleep apnea. Now talk about the sleep apnea itself. What is it? Is respiratory effort is absent or decreased, usually because of central nervous system or cardiac dysfunction. It can be a primary disorder associated with a neurodegenerative disorder, a stroke, or heart failure. It can be in its own or linked to other disease. Initial treatment should focus on management of the underlying disorder if present, such as heart failure. Obstructive sleep apnea is characterized by obstruction of the airway, resulting in continued breathing effort but inadequate ventilation. So you are breathing but not adequately ventilating your lung. The diagnosis is made by in laboratory polysonography or portable home monitoring devices. Example of daytime symptoms include excessive daytime sleepiness, morning headache, personality changes, and poor memory, confusion, and irritability, all due to lack of sleep. The patient may be unaware of their trouble breathing at night. The bed partner report loud snoring, cessation of breathing, choking sound during sleep is very suggestive of obstructive sleep apnea. It has been highly bound to a high BMI, body mass index, a large neck circumstance, an important predictor. However, there is less association in older age. Older patients with obstructive sleep apnea may not be obese and may not have increased neck circumstance. So in older, it's different from the general population. Example of other reported predictor is falling asleep at inappropriate time or napping, and the male gender. Consider the diagnosis in those with a treatment-resistant hypertension. So if we see a patient with a treatment-resistant hypertension, it may be due to obstructive sleep apnea. Alcoholism is an important risk factor, some evidence of an association with dementia. It is treatable condition associated with cardiovascular disease, as mentioned, motor vehicle accident, cognitive impairment, and all-cause mortality. Obstructive sleep apnea refer to sleep. We refer the patient to sleep laboratory for evaluation and, if indicated, treatment. The main treatment is positive airway pressure. Older adults likely to tolerate, as well as younger adults, we give them like oxygen mask to wear during night. It reduces sleepiness and improves quality of life in those with moderate to severe obstructive sleep apnea. Comfort improving devices may improve compliance. Early adherence to predict long-term adherence. Oral applicant may be an option in mild cases. It reduces the blood pressure in AOS, a patient with cardiovascular disease and multiple cardiovascular risk factor. Now we talk about the periodic limb movement during sleep, PLMS. It is a repetitive, stereotypic leg movement that occurs during a non-REM sleep. The prevalence increases with age. Periodic limb movement sleep associated with sleep compliance not explained by another sleep disorder. So it's like periodic movement disorder diagnosed require alponosonography. We mentioned that this is used for to study sleep disorder, alponosonography. Now talk about the restless leg syndrome. It is characterized by uncontrollable, urge to move the leg. You feel like you want to move your leg, usually with unpleasant sensation in the legs that worsen with inactivity. So the patient move their leg to relieve the unpleasant sensation, generally at night time, and improve with movement. The diagnosis is made based on the patient description of the symptoms. The symptoms occur while the person is awake and can also involve the arm. Prevalence increase with age. Albuminosonography not required for the diagnosis. Many patients with this condition also have the periodic limb movement sleep. A restless leg syndrome can be associated with a low ferritin. Check ferritin level in patient with a restless leg syndrome. If iron deficiency is present, treat the deficiency and identify the cause. Now, example of medication that aggravate or induce a restless leg syndrome: antiemetic, antipsychotic, SSRI, tricyclic antidepressant, and diphenhydramine. These medications should be addressed in patients with a new or worsening restless leg syndrome. Now, to treat a restless leg syndrome, symptoms are severe if quality of life is impacted. We give them a dopaminergic agent that is generally the initial agent for choice for older patients. Evening dose of dopamine agonist, paramixoil, is commonly used for patients with a frequent nightly symptoms for restless leg syndrome. Other agents like L-gabapentine used off-label can be effective in patients who cannot tolerate a dopamine agonist. Benzodiazepine and opioid, both used off-label, have been used to treat restless leg syndrome, but are generally not recommended in older patients due to risk of adverse effect. Now we should talk about the circadian rhythm sleep disorder. It is a disturbance in the circadian rhythm of the sleep-wake cycle, may be more common in advanced age. Advanced sleep phase, what does happen? We fall asleep early and we waken early, particularly common in older people. And delayed sleep phase is fall asleep late and wake up late. Irregular sleep cycle is common with dementia and in nursing home residents. So no particular phase or waking up early or late is recognized here. The sleep blocks and rest actinography can be helpful to establish the diagnosis of circadian rhythm disorder, sleep disorder. Refer patients to sleep specialists when symptoms do not respond to initial management, the diagnosis is unclear, or when there is another sleep disorder is suspected. A treatment depends on the particular circadian rhythm disorder. Is it as advanced or delayed? Advanced sleep phase may respond to evening exposure to bright light, and the delayed may respond better to bright light, to the morning exposure to bright light, or evening melatonin. Um, I think, thank you. I think now my colleague, Dr. Mawahib, will continue. Okay, now. Treatment of REM sleep behavior disorder. Excessive motor activity during sleep and pathological absence of normal muscle during sleep. Presenting symptoms are usually vigorous sleep behavior associated with vivid dreams, may result in injury to the patient or the bed partner, may be familiar predisposition and associated with a neurodegenerative disorder like Parkinson's disease and Lewy body dementia. Albuminosonography is needed to establish the diagnosis here. A treatment of REM sleep disorder, if drug-induced, remove the offending agent, environmental safety intervention to protect the patient while sleeping, melatonin, some evidence support it is used in older patients with a coexisting neurodegenerative disorder like Parkinson and Lewy body dementia. Olanzapine off-label is sometimes used in younger people, but adverse effect limit its usefulness in older patient because it is a benzodiazepine. Try to avoid that in older people. I think here my colleague will continue. Mm, sorry. Changes in sleep with dementia. Older people with dementia have more sleep disturbances and arousal, and lower sleep efficacy, and less deep sleep, and more sleep fragmentation, like they wake up multiple times a day during night. And disturbance of sleep wake cycle are more common with dementia, excessive daytime sleeping and night wakefulness. How managing the sleep problem in patient with dementia? We could start with nighttime use of cholinesterase inhibitor, maybe which may can exacerbate the insomnia and can cause vivid dream in some patients. Cholinesterase is used for the treatment of dementia itself. So sedative hypnotic agents have not been adequately tested in patients with dementia. In patients with obstructive sleep apnea, mild to moderate dementia, the positive airway pressure can be well tolerated, improve sleep apnea, and have a beneficial effect on cognition. Um, the daytime bright light exposure have shown more beneficial effect on sleep and circadian rhythm in dementia patient. Okay. Mm, I think here my colleague will continue. Dr. Mawahib. Thank you, everyone.
Thank you, Dr.
Uh,
Sameera.
okay, thank you.
Kindly cease your screen sharing.
Okay, I'll continue to share for you,
Okay, that sounds good.
or you wanna do it yourself.
I'll share it by myself. Thank you
Okay,
very
thank
much, Dr. Sameera.
Okay, thank you, Dr. Sameera.
you. You're welcome.
Dr. Mohab, you can carry on when you are ready.
Mhm. Hello, everyone. My name is Mawahib Mohamed, and I will continue the presentation. So, let's start with the sleep long-term care setting. What are the causes of sleep difficulties? There are many causes of sleep difficulties, multiple physical illnesses, use of psychoactive medications, debility and inactivity, large amounts of time spent in bed during the daytime, increased prevalence of sleep disorders, environmental factors such as nighttime noise, light and disruptive nursing care, as well as lack of exposure to bright light during the day. Irregular sleep-wake cycle is common with dozing and waking off and on over 24 hours. There are non-pharmacologic interventions, and it is the first line approach. Exposure to bright light during the daytime, structured physical, and social activities during the daytime, nighttime interventions to decrease noise and light disruption. Now let's move on to the management of insomnia. There are some important points for a practitioner to consider when dealing with a patient of insomnia, especially if elderly. Do not start an older patient with persistent sleep complaints on a sedative hypnotic agent without careful clinical assessment to identify the cause of the complaints. If the history and physical exam do not suggest a serious underlying cause, mild symptoms may respond to simple sleep hygiene. Chronic insomnia generally does not respond to simple sleep hygiene and requires behavioral treatment such as cognitive behavioral therapy, which is the first time for management of insomnia. Patients should be educated that daytime napping will decrease the nighttime sleep. So, what are the measures to improve sleep hygiene? It is recommended to maintain a regular rise in time, get adequate exposure to bright light during the day, maintain a regular bedtime unless not sleepy, and get up at the same time each morning, decrease or eliminate naps unless necessary, exercise daily but not immediately before bedtime, do not use bed for reading, eating, or watching television, and finally relax mentally before going to sleep. Also, limit or eliminate alcohol, caffeine, nicotine, especially in the evening before bedtime. Wind down before bedtime and maintain routine period of preparation for bed. Control the nighttime environment with comfortable, cool temperature, quiet and darkness. Try a fan or other white noise machine. Wear comfortable bed clothing. And if unable to fall asleep within 30 minutes, get out of the bed and perform soothing activity. Avoid the bright lights. There are non-pharmacologic interventions to improve sleep, and it is preferred over the pharmacologic interventions or the prescription medications. What are these interventions? The first possible intervention, is the stimulus control. The goal is to recondition maladaptive sleep-related behaviors, in which the patient is told to go to bed only when sleepy, not use the bed for eating or watching TV, get out of the bed if unable to fall asleep, return to bed only when sleepy, get up at the same time each morning, and not to take naps during the day. The second intervention is sleep restriction. The goal is to improve sleep efficiency, which is the time asleep divided by the time in bed, by causing sleep deprivation. It is described that the patient first collects a 1 to 2 week sleep diary to determine average total daily sleep time, then stays in bed only that duration plus 15 minutes, gets up same time each morning, takes no naps in the daytime, gradually increase time allowed in bed as sleep efficiency improves. The third intervention is the cognitive intervention. The goal is to change misunderstandings and false beliefs regarding sleep, in which the practitioner identify patients' dysfunctional beliefs and attitudes about sleep, educate patients to change these false beliefs and attitudes, including normal changes in sleep with increased age and changes that are pathologic. The fourth intervention is relaxation techniques. The goal is to recognize and relieve tension and anxiety, in which the practitioner teaches the patient to tense and relax each muscle group, electromyographic biofeedback, give patient feedback regarding muscle tension, and teach techniques to relieve it. Teach meditation or imaginary techniques to relieve racing thoughts or anxiety. The bright light intervention, its goal is to correct the circadian rhythm causes of sleeping difficulty, i.e. sleep phase problems, in which the patient is exposed to sunlight or light box. The best evidence of this is from treatment of seasonal affective disorder from 2,500 lux for 2 hours per day to 10,000 lux for 30 minutes per day. The lux is the luminous flux that falls on a surface. For delayed sleep phase, 2 hours early morning light at 2,500 lux. For advanced sleep phase, 2 hours evening light at 2,500 lux. Shorter durations may be also as effective. Routine eye examination is recommended before bedtime. Also avoid the light boxes with ultraviolet exposure. Finally, the cognitive behavioral therapy for insomnia. Its goal, it combines approaches. Generally, it combines sleep restriction, stimulus control, and cognitive therapy with or without relaxation techniques. Sleep hygiene is, often is included. Now let's move on to the cognitive behavioral therapy for insomnia. It is the first line treatment for chronic insomnia, as it effective in older adults, as well as some evidence that it is also effective in those with comorbid conditions. It combines sleep restriction, stimulus control, and cognitive therapy with or without relaxation techniques. Sleep hygiene is also often included. It generally provided by behavioral sleep medicine specialists, psychologists. Also, it is available in self-materials, online, and using trend-associated health personnel. Now, after covering the non-pharmacologic interventions for the management of insomnia, let's move on to the prescription medications for insomnia. Most sleep medications increase the risk of falls in older adults. Short-acting agents are used for problems initiating sleep, more rebound and withdrawal symptoms after discontinuation. Intermediate acting agents are used for problems with sleep maintenance because of more daytime carryover. Sedating antipsychotics should not be used in routine management of insomnia in older adults. Now, this is a table that summarizes the different classes of treatments or medications that are used for the management of insomnia. However, they are generally not preferred. The first class is the intermediate acting benzodiazepine, like temazepam. The comment section contains the side effects of each class of the medications. However, generally, most of these medications increase the risk of falls in elderly. Therefore, they are avoided. Short-acting non-benzodiazepines like isopeplone, zaleplone, as well as zolpidem. Melatonin receptor agonists like ramiltion and tasmiltion. Orexin receptor antagonists like suvorexant. Sedating antidepressants like doxepin, trazodone, and mirtazapine. The chronic hypnotic use. In studies of benzodiazepines used for sleep, it is found that prevalence of use increases with age, and chronic use increases morbidity and mortality. Chronic use may exacerbate sleep problems. To help patients eliminate use, a practitioner needs to decrease the dose by half for 2 weeks at a time prior to full withdrawal. Patients with a long history of use may need to taper more slowly. Also provide cognitive behavioral therapy for insomnia prior to or as part of the tapering protocol. There are also non-prescription sleeping agents. They're used by nearly half of older adults. The first one is melatonin. There is insufficient evidence to recommend in the treatment of chronic insomnia in older adults unless another disorder that responds to melatonin is present. There are not recommended options like sedating antihistamines because of the anticholinergic side effects, alcohol, as it interferes with sleep later in night. In addition to other health concerns, valerian is a herbal product. It has little effectiveness, and kava is a herbal product as well. Significant adverse effects events, including hepatotoxicity. So choose wisely. Recommendations based on the American Board of Internal Medicine Foundation's Choosing Wisely campaign recommend that do not use benzodiazepines or other sedative hypnotics in older adults as a first choice for insomnia, agitation, or delirium. To sum up, in older adults, insomnia generally occurs comorbidly with other psychiatric, medical, or neurologic illnesses. Cognitive behavioral therapy for insomnia is first-line treatment for chronic insomnia in all adults, including older people. Polysomnography is indicated if a primary sleep disorder is suspected or patient doesn't respond to treatment. Now let's move on to the cases. The first case, an 80-year-old woman comes to the office because of 6 months history of difficulty staying asleep. She frequently naps during the day. She is accompanied by her husband. Her nighttime awakenings also affect his sleep and overall quality of life. She usually falls asleep easily around 9 or 10 p.m. and then wakes up after 2 hours. She may get up to the bathroom, and the pattern of sleeping for a few hours at a time continues until her scheduled wake time at 6 a.m. She has at least 3 awakenings during the night, each lasting from 30 to more than 60 minutes. She sleeps after breakfast for 2 hours and takes 1 to 2 naps in the afternoon. She sometimes appears more agitated in the evening. Her history, she has moderate Alzheimer's disease. Which of the following is the best treatment approach of this patient sleep disorder? Is it melatonin at scheduled bedtime, trazodone at scheduled bedtime, cognitive behavioral therapy for insomnia, or bright light exposure during the day?
B.
Yes, it's bright light exposure during the day. The second case, a 75-year-old man comes to the office because of the past 2 years. Because for the past 2 years, he has been bothered by excessive daytime sleepiness. He falls asleep at church, theater, and during meetings. He notes that his sleep is restless and no longer refreshing. His wife says that he snores slightly, and sometimes she hears him gasping for air. He brings results of a sleep study, polysomnography or polysomnogram, done at another facility. Total sleep time, 5.7 hours. Sleep architecture, all sleep stages recorded. Reduce slow wave sleep, stage M3. Sleep efficiency is 78%. Apnea, hypopnea index, obstructive 5.2, and central 16.4 in Chine-Stokes pattern. Lowest oxygen saturation is 88%, and he has a history of heart failure with ejection fraction of 38%. Which of the following therapies is least likely to be beneficial? Is it nocturnal oxygen, adaptive seroventilation, continuous positive air pressure, or continuous positive air pressure with nocturnal oxygen? So the answer is B, adaptive seroventilation. The third case, the final one, a 76-year-old woman comes to the office because her symptoms of restless leg syndrome have worsened and because she has felt depressed since her husband was diagnosed with multiple myeloma 4 months ago. The restless leg syndrome had been well controlled with pramipexole 0.25 milligram at bedtime for the past 2 years. She has a history of restless leg syndrome, of course, depression previously resolved with pharmacologic therapy, and renal disease. Which of the following antidepressants is least likely to increase symptoms of restless leg syndrome? Is it venlafaxine, mirtazapine, bupropion, or paroxetine?
So B. B.
The answer is C, it's bupropion. Thank you very much for your attention, and this concludes our presentation on sleep issues. Thank you very much. And if there are any questions, please go ahead.
Thank you, Dr. Sameera and Dr. Mawahib, for this amazing presentation. And if anyone has a question, you can ask in chat or open the mic. So now we can carry on with our tool in this meeting. Today we will have Microsoft PowerPoint Coach tool with Dr. Dalia. Dr. Dalia, you can start when you are ready.
Hello, everyone. Hello, Dr. Nadir. Assalamu alaikum wa rahmatullah. Good afternoon. Today we have a nice topic. I will start sharing my screen. Our topic today about Coach PowerPoint tool. First, I will start my presentation with one question for all of you. Have you ever practiced presentation in a mirror, wondering if you were speaking too fast, using too many arms, or just sound a bit monotone? I think a big part of us will answer yes. Today we will try to solve this problem with the new version of artificial intelligence tools. And now we will go together to know about this. This tool is AI-driven tool that can act as your personal public speaking coach, helping you refine your delivery and build confidence. We will be exploring the ins and outs of the PowerPoint speaker coach and how it can transform the way you prepare for your next big talk. What is the PowerPoint presenter coach? It is also known as speaker coach or presenter coach. It is a built-in AI-powered feature design to help you improve your presentation and public speaking skills. It provides real-time feedback and a summary report after you have rehearsed your presentation. What is the key feature and how it works? A speaker coach acts like a private virtual coach, analyze various aspects of your delivery. It is available in multiple platforms, including PowerPoint for Windows, Mac OS, the web, iOS, and Android. Now let us to discuss the key areas it provides feedback on. This AI provides us feedback in pacing. It monitors your speaking speed, altering you if you are talk too fast or too slow, so you can find comfortable rhythm for your audience. Also, it detects the pitch. It can help you vary your pitch to avoid sounding monotonous, which can disengage your audience and make your presentation very poor. This AI also detects the filler words like and which we use many times in our presentation, and helping you to reduce them and sound more confident. It also acts in identifying when you are simply reading the text directly from your slide, encouraging you to summarize points and speak more naturally. The other area is inclusivity and sensitivity. It provides feedback on culturally sensitive terms, informal language, and profanity, helping you to ensure your presentation is appropriate and respectful to all audience members. And this very important part is the body language, but this we cannot find in all versions, only in web version. The web-based version can use your camera to provide feedback on your body language, just as whether you are too close or too far from camera, or if you are looking away from your audience. It also detects the pronunciation. In some version, it can even detect and help you practice mispronounced words. And this is very helpful. What is the benefit of using a speaker coach? Before I will start to present this slide, let us to go and see and demonstrate how this coach working. How you engage in this coach working? You open your PowerPoint. As you see here, you go to the first upper bar. You find here file, home, insert, draw. You go directly to slideshow and click on slideshow. Will appear this bar. You will choose rehearsal with coach from this bar. Click on rehearsal with coach. As you see, there is the bottom part. They said, welcome. See live feedback as you rehearse. From here, you can start rehearsing with your coach. Now, I will excuse you that I will present these two slides in not good way, and will try to find my defect through this process. I will start my rehearsing with click starting. Also, there is an option to show real-time feedback. If you tick on this, show real-time feedback, they will give you real-time feedback when you do anything not appropriate. If you said an appropriate word, or you go very slow, or you go very fast, they will give you alarm. You do something wrong, take care. So they will give you something like a ring. I will make it. I don't know, you can listen to this ring or no, but try to see. We're starting now. This is slide about benefit of using speaker coach. Improve skills. It provides specific actionable feedback on your delivery, helping you to become a more effective and engaging speaker. Increase confidence by practicing in appropriate. You see, they give me alarm. Increase confidence by practicing in a private. Give me alarm that I use if you see here. Judgment-free environment, you can build confidence and reduce nervousness before a real presentation. Here, guys, if you see in this point, guys, you have keep going. Every time they give me here a comment about what I do, I will make it silent to see, give me I will make it silent to see what will happen at the end. Efficiency, it allowed you to practice and refine your presentation at your own pace without needing to impose on colleague or friend for feedback. Other benefit is data-driven learning. The final rehearsal report because I close this, here not appear anything. Not appear in the screen. Give you summary of your performance with statistic and recommendation, allowing you to see your progress. Now I talk a little bit fast and focus on area for improvement. Free and accessible. It is available in feature for all Microsoft 365 user, making a professional level presentation coaching accessible to the wide audience. Now we are finished. We need now to check what happened and show. Immediately will appear this full screen and give you the review of rehearsal report. Here you will find what you do. The summary. This is a 4-slide rehearsal. Take total 2 and 56 minutes. They give me comments that I use filler like relative language. This I will ask Dr. Nader about it because I use repetitive language, but here not appear. Here give me about pace. Your pace just right, keep it up. That is mean I am slow. I need to be more fast. Here they give me the pace over time that I am going up and down, and here they give me about pitch. Sometimes I speak very low, and sometimes I speak with high tone. Here need to give me that I am reading from a slide. I am not engaging with other people in the audience. The important feature in this, you can detect where your defect, so you can repair it in the next time. And the other important one is rehearse again. You give you the opportunity to rehearse again, so you can repair your mistake, and you see the area where you make a mistake and defect and more arms, and you are slow, and you use monotonous tone, and you repair all these and rehearse again to get the feedback. This all about our presentation. The other feature also is learn more. This, if you click in learn more, they will open to you a new website. They give you a lot of idea and advice to how you can present in a good way, to make a good presentation. I will close this, and this is the end of my presentation. I want to try to use this. I think it is helpful. But my question for Dr. Nader is that I find when I am preparing this slide and try to know more about this rehearsal coach, that in the video there is a lot of feature not find. Maybe my version is old, but I think it is good for practice. And the other thing, I think if we use the web version, it will be very effective because it will give you the gesture. If you are near to camera, if you are far from camera, I think it is a very good tool. Dr. Nader, what your insight about that?
Yeah, thank you, first of all, for your presentation and all other presentations. Yeah, I agree. I think it's just the version. Each time they may add new features in PowerPoint and on their web version. So most likely it's just because of the either old version or different one.
Yes. The other question for you, Dr. Nader. You think nowadays we are in the last days of application submission before many days. You think this tool can the applicant use for preparing for interview preparation?
Oh,
It will
sure.
be
That's a good idea, and it's a good tool. So usually what we do in the past, or what we did in the past, is we ask you guys to work together as teams. You can select someone who know you, for example, another fellow, or maybe your family member, and then you practice. They can ask you the questions, and then you practice your answers. And but this tool, it will help you because it can, as you display it or demonstrate to us, that it can pick up on certain things like the or repetition, or your tone, or your speaking speed. So usually this is not picked up by the person that you do the mock interview. So I think it's a good tool to add it to the tools that you use for preparation for the interviews in the future. But thank you so much.
Thank you, Dr. Nadir. Thank you, everyone. And if anyone have any question. Thank you.
Thank you, Dr. Dalia, for this presentation. It's a practical and valuable tool. And it's always better to learn with the experiment. So thank you for that also. We can now carry on with our next part of the agenda. It's lessons learned from the most followed doctor on social media for IMDs in the US with Dr. Mahlet Abri. Dr. Mahlet, you can start when you're ready.
Okay, thank you, everyone. Good afternoon and good evening. Do you want me to share my slides, or can you share the uploaded ones?
Yeah, it would be better if you can share it.
Okay. Can everyone see my slides?
Yes, it's clear.
Yes.
Okay, thank you. First of all, I would like to thank Dr. Nadir and all my fellow colleagues here. I think this topic will give us some insight as to how we can use the different social media platforms to promote ourselves as IMG. So as an introduction, I would try to outline that social media is a very powerful tool for education, advocacy, and networking. And as IMGs, we face unique challenge as we are expected to adapt to a new system to create credibility and to create connection. And in this journey, we can learn from the success of other physicians who are influencers. Based on your preference of social media usage, whether it's in Facebook, YouTube, TikTok, or Instagram, there are a number of clinicians that have tried to promote their product, or that have tried to increase awareness regarding health, and will try to, instead of picking an individual, we'll try to see what are the tips or the suggestions that they have as role models. So the first one is approachability, and to add education in their content. The other is to create relatability by incorporating humor along with science in their communication, as IMGs also to be able to express the different cultural backgrounds we have incorporated with creativity, and to also advocate for the patient or give a patient-centered content. And we'll try to see this in more elaborated terms. So authenticity is, as especially as IMGs, we have a different journey, and sharing our journey, whether it is, whether there are ups and downs, challenges, it's always expected that as IMGs we overcome a number of challenges, and sharing that would showcase our strong feature, which is our resilience. And if you have what we have learned about different programs and their interest in resilient candidates, so we need to create that our presence as a resilient candidate. We need to showcase our resilience in sharing our journey. The other is to build trust and community, and in order to do that, we need to give credible information and we need to be engaging. So we'll try to see that as well. The other important lesson is to add educational value. So as we all know, explaining a medical terminology to patients who are not in or who are very new to the medical terminology, we need to use simple words, and we need to try to incorporate expressing or incorporate giving that knowledge using different visual aids, analogs, and storytelling. So that helps to really create awareness, which is a very significant contribution or educational value in promoting healthy life. And in order to do that, we also need to have accurate information. As you know, medicine is a very dynamic field, and there are updates every time. So we need to be able to give an updated, accurate information, and we need to make the sources of those information also accessible. So adding educational value should be a core concept in sharing experience or in creating a presence in social media platform as a physicians. The other lesson that they shared to increase success in social media presence is consistency, and having a regular rather than sporadic activity or sporadic topic sharing or teaching, having a regular presence in this social media create consistency, and it also build presence. And the other thing with consistency comes reliability, and people tend to engage with individuals who are consistently trying to teach others in that particular topic. So they share that consistency is another success for having a good social media platform. The other topic is the other important tip that they shared is to have a balance in professionalism and creativity. So as you all know, in this day and age where certain topics are, discussed become very viral and the like, trying to just engage with your community just to get, a sensational topic or to just have a large number of views. Rather than doing that, it's always advised to have a professional behavior and try to not just respond for some hot topics, instead to stay grounded to the core idea or to the core value that we try to promote in our social media presence. So we need to make sure that we don't create misinformation, or we should avoid sensationalism, and we should, as also clinician, we should always maintain confidentiality and respect the HIPAA rule. So we should not be able to discuss individual patient information in our social media platforms, but we can use the identified information to just help elaborate our topics and the information that we want to convey to our audience. The other very important thing that all these successful social media physicians and clinicians share is that they have something they're very passionate about, and they have something they strongly identify with. So some examples could be, we know there are different clinicians that serially show cases and try to engage and teach fellow colleagues or the public using different case scenarios. For example, could be from internal medicine. There are also other individuals who promote wellness, who promote also as IMGs. There are different groups that we follow, especially that try to showcase or navigate IMGs in their journey in the USMLE and the like. So we should find something that we are passionate about, and we should try to work on that, increase our knowledge in that topic, and try to share that. The other important tip for success in social media is engagement. So we should be able to respond to questions. We should be able to build an opportunity for a bidirectional dialogue and to learn from the audience feedback. So these are this is a common recommendation for many different platforms, but I want to just dedicate this one slide for LinkedIn Success, because it's one of the professional platforms where we can promote ourselves, create connections. And for LinkedIn Success, there are certain tips that are provided. And among this is to have a professional picture in your LinkedIn profile, to create a clear title, and your title needs to be an updated one, and it needs to showcase your area of expertise. The other is to optimize summary. So in summary, you can describe the areas that you are passionate about, that you want to achieve. In terms of experience, it's nice to showcase the different backgrounds that you have, the different experiences, whether it's in teaching, in collaboration, in clinical service and the like. The other is to use the section where skill and endorsement is. We need to use this area to showcase our different skills, like interpersonal communication skill, our time management skill, our if we have very good skill in research paper writing or the like, we should use that. And we should also ask for endorsement. It's sometimes nice to be able to have an endorsement from individuals that we have worked in the long run, or that we have worked for a long time with. The other is the educational and certificate portion. It's also relevant to showcase the different educational and certificate that we have, to showcase our qualification. Recommendations are also similar to endorsement, but it's important to fill these areas in our LinkedIn profile. We need to, the other, aside from, the profile side, it's better if we are individuals who can engage, for example, who can share new information or new research in the industry or in the area that we focus on, and that will help us to be engaged and to show that we are an active member. Also engaging with your connections, like messaging, direct messaging, and the like are also important. And the other is to join a group that we are inclined to, that we are passionate about, or that we think are helpful in our professional development. So these are some of the tips that are provided when it comes to LinkedIn Success. The things that we need to avoid is to advise outside of our scope, especially if we are trying to be, to create a presence in social media. We need to avoid ignoring ethics, especially in keeping, patient privacy and professionalism. As you said earlier, HIPAA, respecting the rule of HIPAA is very critical. Rather than, chasing popularity, we should also focus on credibility for anyone who wants to build a social media platform. Credibility is very vital. And as we said earlier, having a consistent presence is also important. So avoid inconsistency. Why this matters for IMGs? As IMGs, we've said earlier that we need to prove that we are credible, that we are knowledgeable, that we have, good interpersonal skill, communication skill, and the like. We need this as IMGs to build our professional networking and visibility, and we know how important that is, especially when it comes to, having a spot in residency programs. It will help us to showcase our communication and teaching skill, and it will also advocate for global health and diversity, because we come from different, background and different health experience, health sector experience. That will help us to advocate for patients, and it will also strengthen our application as a resident. So this is some of the important aspects of the media when it comes to IMG. So again, as a conclusion, we can use social media as an opportunity to increase our visibility and to showcase our resilience and competency, and authenticity, education, consistency, professionalism, passion, and engagement are very important. And we can, if used wisely, these platforms can help us inspire others, educate others, and connect with like-minded individuals. So this is a wide topic. I just try to focus important aspects when it comes to being a professional in different social media platforms. If you have any questions or suggestions, please, everyone is welcome. Thank you.
Thank you, Dr. Mallet, for this interesting presentation. Having social media presence is, we can say, critical these times, as it can open many opportunities, even outside of residency or match application. Thank you, Doctor. Dr. Nader, do you have any comment?
This excellent, wonderful presentation. Thank you so much. And I think it's very important to make sure every one of you who is planning to apply this year to have at least some presence in the social media as presented professionally here. So make sure you have LinkedIn or other presence, so that some of the programs might look at your page and get more information about you. So good luck. Thank you so much for this great presentation.
Thank you. Thank you, everyone.
Thank you, Dr. Nader. So now we have our next topic in the agenda, CBL presentation with Dr. Marian. Doctor, you can start when you are ready.
Good afternoon, everybody. Today we have an interesting case. Let me share my screen first. Are you able to see my screen?
Yes.
Okay. So today our case is a case of chronic itching and hip pain in a young woman. So the patient is a 19-year-old female. She has a 1-year history of generalized itching with along with bilateral hip pain with flexion. It was worse on the right side, and the onset of the hip pain is 6 months after started 6 months after the itching. She tried to use over-the-counter creams and clotrimazole, and it didn't help. And the patient doesn't have any travel history. Now we have the positive pertinence from her physical examination and from her initial lab work. So her blood pressure is 142/87. Her heart rate is 55. The skin finding is a scaly, flaky rash on her lower back around the waist. The joints didn't show any swelling or erythema, but she had pain with flexion. No other systems are involved during the physical examination. Her initial lab work showed transaminites, leukopenia, and elevated ALP. So do you have any, what do you think it could be?
I think it might be related to biliary, maybe BBC.
Okay, this is one of the differential diagnoses. Anybody else? Okay, the point
Maybe it's
here,
related to any autoimmune disease like SLE or
yes, correct. Any other differential diagnosis? Okay, so the important thing here is the mix between the dermatologic finding and the systemic finding as well. So from the findings that we have, the patient, if you notice, she has a bradycardia, which is abnormal in her age, along with the elevated blood pressure. Also, there are findings for the elevated transaminites and the elevated ALP. It like at push beyond like only dermatologic disease. There is systemic involvement in this patient. So so the first thing here is Lyme, that we should rule out Lyme disease or Lyme carditis. Yes, the patient, she doesn't have any known tick exposure, but there is systemic symptoms along with the rash and the bradycardia. As the doctor mentioned, the systemic lupus erythematosus, because the patient has a scaly rash, fatigue, the transaminites, elevated liver enzymes, along with the leukopenia, are highly suggestive. Also, the transaminites could suggest the autoimmune hepatitis and maybe the primary biliary cholangitis as well, because she has elevated transaminites, pruritus, joint pain, and fatigue. And it could be hypothyroidism because the patient has bradycardia, she has fatigue. It could be thyroid dysfunction. The last thing we have on the list is vitamin D deficiency. We should exclude that due to the elevated ALP. So based on this differential diagnosis, what's your plan and what do you want to order?
have to do a CBC, complete blood count, and also have to measure the thyroid stimulating hormone. And we do like also antibodies to measure like regarding SLE, we can do anti-double strand DNA or aromatic factor also. Can
Yes,
make
yes.
also X-ray for the knee, I mean for the hip joint, rule out any inflammatory process.
Correct. Okay, so first to rule out the Lyme disease, we can order the Lyme serology ELISA, and if it came positive, we should order the Western blot. For systemic lupus, we can order the ANA, anti-double-stranded DNA, and C3, C4. For the autoimmune hepatitis and the primary biliary cholangitis, we can order anti-smooth and muscle antibodies and anti-mitochondrial antibodies as well. For the possibility of hypothyroidism, we should order TSH, F4, free T4 and T3. And because the patient has bradycardia, we should rule out any cardiologic disease and run an EKG to evaluate this bradycardia. So the results of these labs came back positive Lyme serology. So why this case is tricky? So this patient has no travel to endemic areas. She was in Orlando, Florida. In the beginning, for almost a year, her rash was misinterpreted as eczema or fungal infection. They overlooked the bradycardia as benign cause. Her musculoskeletal symptoms not linked to systemic disease. So more workup for Lyme carditis, like why it's Lyme carditis. It's early disseminated Lyme disease. The cardiac involvement is due to conduction abnormalities, AV block. The dermatologic clue, it's atypical erythema migrans, and the musculoskeletal involvement is migratory arthralgia. So we already talked about that. So the management plan for this case, if it's mild carditis only, we would prescribe oral doxycycline. If there is severe atrioventricular block or symptomatic bradycardia, we would prescribe intravenous ceftriaxone. We should monitor the cardiac rhythm and educate the patient on tick prevention even in non-endemic areas. So the key takeaways from this case is Lyme disease can occur outside endemic zones, and cardiac symptoms may be subtle, and it could go unnoticed. Rash may be misdiagnosed, and always consider systemic causes of pruritus and arthralgia when they are combined together. So there are 3 questions based on this case. What clues pointed out toward Lyme carditis? This is the first question. Bradycardia, heart rate 55 in a young adult with no athletic history, raises concern for conduction abnormalities. Her elevated blood pressure may reflect autonomic involvement or early cardiovascular stress. Her scaly rash on a lower back and waist could represent an atypical erythema migrans, especially when unresponsive to steroids. The hip pain with flexion suggests sacroiliac or migratory arthralgia, which is common in early disseminated Lyme. The lack of improvement with the topical treatment and multi-system involved hint at a system etiology. How would you approach this case differently in an endemic region? So if this is, for example, in Minnesota, so Lyme disease is very popular in this region. and it would be higher on the differential from the beginning. Earlier serologic testing and EKG would likely be performed, and the rash might be more readily recognized as erythema migrans. Empiric antibiotics treatment might be initiated sooner, especially with cardiac signs, and public health awareness and clinician familiarity would reduce diagnostic delay. And the opposite for this, how does geographic bias affect diagnosis? So usually in this case, clinician may prematurely exclude Lyme disease if the patient lives in a non-endemic area like this case. The bias can delay diagnosis and treatment, especially when symptoms are atypical or there is overlap with common conditions like eczema or mechanical hip pain. It underscores the importance of considering the exposure risk like outdoor activity, pets, and travel. Educational gaps and lack of local awareness may also lead to undertesting and misdiagnosis. Thank you. If you have any question, I'm happy to answer.
And so I have a question regarding itching. Do you think Lyme disease can cause itching? Like she has perioditis. So why we put Lyme disease as maybe with bradycardia and arthralgia is okay, but regarding the itching and
this is how, that's a good point, but this is how the patient described her symptoms. So like during the physical examination, there was nothing like to say if it's erythema migrans, but she described it as itching. And the only thing that was positive regarding her skin examination is like scaly around her waist, which actually pointed more towards contact dermatitis.
yes, I mean that. And also, how about the immunological test? If I did it, for example, if she gets this Lyme disease in the first week, so I think the antibody is not appearing this time. So we have to treat it as empirically as just give her like doxycycline regardless the result of investigation, because the immuno antibody is not appearing the first week or second week from Lyme disease.
Sorry, I didn't get your point. Can you repeat your question?
I mean, like, if you said we have to do like test for Lyme disease, right? We have to do to check the antibodies.
We do the serology test, the ELISA test, and if it's positive, we do the Western blot. Yes.
Yeah, I mean, like, we have to treat it clinically, or we have to do the test, because I think the antibody is not appearing in the first 2 weeks from Lyme disease exposure.
So usually, if it's as we mentioned, if it's like in region that is like common, like Minnesota, for example, so they would treat empirically if they suspect there is Lyme carditis, and they start immediately and they don't wait for the lab results. But because this patient was in a non-endemic region, so it was not on the top of their differential diagnosis, and this caused a long delay. It was like almost a year.
So we have to treat her empirically.
Yeah. Does this answer your question?
Yes, thank you.
Thank you. Thank you.
Thank you, Dr. Marian, for this unusual presentation for Lyme disease. If anyone have a question, please, you can write it or open the mic. Okay, so now we can continue with our final aspect of the agenda of our meeting today, which is the project's update. Dr. Nader.
Thank you so much. So anyone with any updates as far as projects or as far as new ideas? I know some of you might be new to the program, but we have some videos regarding the preparation for the interview during this coming season. So if you look at the app, we collected some of the mock interviews that were done by some of the fellows in this program, so you can watch them. And there are some tips that also they shared, so you can learn from them and maybe you can improve your skills. And there are some other videos available also we collected from the web or YouTube that also will show you some of the tips that or skills that you need to practice on and prepare for the interviews. So the app itself, you can use it and locate all these videos. Hopefully it will help some of you during the interview season. As far as letter of recommendations, some of you requested and I uploaded them. And if you still need some of these letters, please let me know. Email me, send me the request, and on the app, update your activities or your task, your achievements, so that your letter will be personalized. Anyone would like to share any thing as far as your projects or any ideas, questions? Any final thoughts, Dr. Salam or any of the team?
Thank you, Dr. Nader. Our fellow researchers, thank you for joining us today. And hopefully, we could have provided you with useful information used in the near future.
Thank you so much to you and all the presenters from today. Thank you for a great job and wonderful presentations. Thank you all who attended today. And I'd like to thank those who will watch the recording in the future. I hope you all have a wonderful day and I wish you all the best. If you have questions or ideas or any need for assistance, please contact me. You can send me an email or you can call, text, or WhatsApp me. Thank you again, everyone. Have a wonderful day or night. See you next week. Assalamu alaikum.
Salam. Thank you.
Thank you, Dr. Nader, for your support. Assalamu alaikum.
Alaikum salam, Dr. Dalia. Wish you all the best.
Thank you, Dr. Nader. I appreciate it. Thank you very much.
Anytime, Dr. Azza. Thank you so much. Have a wonderful day.